Hi, my name is Seonaid, and my master's project involved fabricating a paediatric chest phantom, which I used to assess the appropriateness of using added tin filtration for non-contrast paediatric chest CTs, specifically for infants. So firstly, I'd like to acknowledge my supervisors from Medtech and Physics and UWA and my friends and colleagues who supported me throughout this project. So paediatrics are particularly susceptible to the harmful effects of radiation for a couple of reasons. So they are still growing, so they've got more rapidly dividing cells, and they also have many more years to live, in which unfortunately they could produce a cancer that was caused by an exposure to radiation. So when considering paediatric CT, referrals should be very carefully justified, and importantly, the doses should be optimised. So we want to keep radiation doses as low as reasonably achievable. Now, the Siemens Somatom Force dual source CT scanner has been implemented, has optional added tin filtration on both X-ray tubes, so it's a dual source CT. Unfortunately, no judgment. The tin filter is only available using 100 kVp or 150 kVp. Now, the tin filter is used for ultra low dose imaging on the Siemens Force. So considering tin as a filtration, it's quite a heavy filtration with an atomic number of 50 compared to traditional filters like copper and aluminium that have an atomic number of 23 or 13. Now, Siemens recommend that Siemens have provided the tin filter for a low dose imaging option for anatomy that has inherently high contrast, because the tin is a particularly heavy filtration, and with this filtration you get a lot of low energy X-rays absorbed from the beam spectrum, which is associated with a loss of photoelectric absorption and a loss of inherent image contrast. So taking a closer look at 100 kVp spectrum with and without tin filtration, we can see immediately that, that the tin filter heavily attenuates a lot of X-rays in the beam spectrum, but preferentially the low energy X-rays, so you do get a shift in the average energy of the beam spectrum, which creates a hard X-ray beam. So this hardening of the X-ray beam is not immediately apparent whether there would be benefits using it in the field of paediatrics, where traditionally we would lower the kVp, so a 70 kVp is more appropriate for paediatric CT scanning traditionally. So various studies have considered the use of added tin filtration at 100 kVp for low dose non-contrast paediatric CT studies. I'm only going to talk about the most recent one, a study by Vivia et al., where they is a clinical study where they aim to match the DLP for patients using 100 kVp with added tin filtration and 70 kVp. And they found, interestingly, that for patients larger than 15 kilograms, there was a reduction of noise using the tin filter, but there was no significant improvements in image quality when using the tin filter at 100 kVp for patients that were smaller than 15 kilograms. So this is sort of where my project focuses on. So I had 3 research objectives for my research. So the first one was to create a paediatric chest phantom that would approximate the attenuation and scattering conditions in a very small child between 0 to 1 years old. My second objective was to use the phantom to perform image quality assessments, assessing the paediatric CT protocols with and without the tin filtration. My third objective was to use the phantom to perform comparative dosimetry assessments, and ultimately these 3 objectives would address the appropriateness of using the tin filter at 100 kVp as opposed to using a low kVp for non-contrast chest CT studies. So, my phantom. At the beginning of the construction phase of my phantom, I wanted to replicate paediatric tissues. So firstly, I performed a clinical survey of Houndsfield units in paediatric tissues. So this involved measuring the Houndsfield units in different structures in paediatrics that had recently been scanned on the Siemens Somatom Force. So as you can see, I've tried to illustrate here sort of the method that I chose. So I measured Houndsfield units in all different structures in many, many patients. And I also looked at the low kVps and the tin filtered kVp. So I looked at 70, 80, 100 with and without tin filtration. So the results of the measured Houndsfield units are displayed here. So you can see I've got lots of data for the range of Houndsfield units that appear clinically in different structures within patients, but also for different energies. So I can see how the Houndsfield units change from the low kVp compared to the heavily filtered tin kVp. So the materials that I chose to use in my Phantom, I had 3 main tissue substitute materials. So a soft tissue, a bone, and a lung tissue substitute material. Now, cutting a really long story short here, the materials that I used were polymethyl methacrylate, or PMMA, which is a type of acrylic which is commonly used in diagnostic imaging. For example, the standard CT-DI Phantom is a cylindrical Phantom made of PMMA. So it's really appropriate for modelling soft tissue, as it approximates the absorption coefficient of water in diagnostic energies. So for the bone substitute material, I chose to use a silicon-based rubber solution called Uracil 10 with added amounts of calcium sulfate dihydrate. The solution comes in 3 parts. You mix it together and you can set it easily into any shape that you want. For example, the ribs and the spine of my Phantom, and I left it overnight, and it solidifies overnight by itself. For the lung substitute material, the best candidate was cork. So I used sanding blocks. They were really cheap, easy to get from Bunnings. So the design of the Phantom started off as pen and paper, and it really first came to life with the help of the engineers in medtech and physics using a computer-aided engineering software called SolidWorks, which it was later transferred to the MasterCam program, which is compatible with the CNC milling machine and medtech and physics. So I'm just going to play this so that you can get a little bit of an idea of how the Phantom came together. So it started off in sheets of Perspex, from which the CNC cut out the different sections of the Phantom. So the middle section is still soft tissue, but it's actually all of the slices are held together by a acrylic rod. And so the base of the Phantom is acrylic, and the bone substitute and the tissue substitute materials were filled into the cavities after they were cut out. So I'll just move on because I don't have enough time. Oh, moving back. Oh, God. All right. So just to paint a little bit of a picture about the construction phase of the Phantom. So this is me mixing up the rib substitute materials. So I wanted to get the right density and concentration to approximate paediatric bone, and just injected them and set them overnight into the Phantom slices. Similarly for the spine, and the cork pieces were cut out and shaved back to make sure they fit properly. I was not allowed to use the bandsaw, so the lung material was cut by a trained professional. No stress. Now, just quickly before I validate the Phantom materials, this is my proud mama moment. So this is my Phantom, scanned under CT to look at the tissue substitute materials compared to a real patient about the right age that we're looking at. So this is my baby. All right, so for the validation of the Phantom materials, what I did was I scanned the Phantom at many different energies, but particularly looking at the 70 kVp, because it's most appropriate for paediatrics. You can see here the measured Houndsfield units in the actual tissue materials compared to the data that I found in the clinical survey. So you can see for each tissue substitute material, the Phantom material falls within the range observed clinically in paediatric patients. So this was also important to perform the validation at the 100 kVp with added tin filtration, because that's what my Phantom was supposed to do, was to compare the two. So after the Phantom materials were all assembled, my Phantom slices needed to be modified to allow the assessment of image quality and dosimetry within the Phantom. So 4 slices of the Phantom were dedicated to performing thermoluminescent dosimetry. So slices 1 and 4 in particular were modified to make the phantom more anatomically representative of a baby. So this included removing the lungs from slice 1 and replacing it with soft tissue. This would model the shoulders of the patient, and I included a TLD position for a thyroid dose. At the opposite end of the spectrum, slice 4 was the base of the lungs with a soft tissue insert and a TLD position to estimate a liver dose as well. So these regions are typically included in a chest CT scan for paediatrics. So the majority of the rest of the TLDs were positioned between slices 2 and 3 as a bit of an array of different doses being deposited in different tissues. Now, 6 phantom slices were dedicated to measuring different aspects of image quality. For example, in slices 5 and 6, I've got inserts modelling both soft tissue and lung, with inserts blending slowly into the background. And this was designed to measure the low contrast resolution within the images. Slice 8 has wire inserts, which are appropriate for modelling the MTF of the imaging system, as well as measuring the distance accuracy. Slice 7 and 10 were custom-made acrylic slices designed to measure uniformity. So this is the end result. I got a paediatric chest phantom that comes in many slices, and its tissue materials have been validated and is capable of performing image quality and dosimetry assessments relative to an infant in a CT. So the second objective was to use the phantom to perform image quality assessments. So I did this in 2 parts. So firstly, I did a dose matched assessment where all of the automatic settings of the CT were switched off. The filtration and the KVP were manually selected. The MA was adjusted to match the CTDI to be as close as possible to 0.2. Now, I chose to select as many protocols as possible, so I did 70, 80, 90 and 100 KVP without TIM filtration, and 100 and 150 KVP with TIM filtration. Now, these protocols are separate, and it's hard to explain by beam energy, so I'm just going to call them all different protocols. So these are the protocols that I tested. So I tested the same protocols for the quality matched image quality assessment. So in this case, the automated tube current modulation was switched on, which is a little bit more clinically appropriate. And in this case, the quality reference value was matched. So that was set to a value of 30 MA. So the image data was reconstructed in the same way for both the dose matched and the quality matched assessments. The image data was reconstructed in 1 millimetre axial slices in both a soft tissue reconstruction and a lung reconstruction. So a smooth and a sharp, which is what they use clinically. Every chest CT gets reconstructed into the smooth and the sharp. So for the image quality analysis, I assessed the structures in the mediastinum using the soft tissue recon, and similarly for the lung in the lung recon. So assessing the noise and the contrast to noise ratio would give information that I could use to calculate a figure of merit. So a figure of merit is tries to consider the image quality produced normalized for the dose delivered. So this is a metric that's used in the literature to evaluate the dose efficiency of the different protocols. So this is what I used to analyze the tin filter versus the non-tin filter. So jumping straight to the results, the figure of merits for the dose matched assessment display that the tin filter, the tin filter at 100 kVp actually proved to be the most dose efficient in this case, so for the matched dose. When comparing to all of the protocols that would without the tin, interestingly, the tin filter at 150 kVp, was the least dose efficient. So I had the lowest figure of merit score. And this trend was seen in both the reconstructed mediastinum images and lung images. However, when considering the quality matched assessment, the results for the figure of merit were quite different. So In the mediastinum reconstructed images, again, the tin filter at 100 kVp proved to be the most preferred protocol, proving with the highest figure of merit. However, for the lung reconstructed images, the 70 kVp was the most dose efficient, closely followed by the tin filter at 100 kVp. Interestingly, it's a quality match study, so the CTDI values were very different, and the doses displayed in these images, the doses delivered while producing these images were very different. Considerably very low using the tin filter at 100 kVp, which resulted in a significant amount of image noise and reduced contrast to noise ratio, so definitely a degradation of image quality. However, the ultra low dose is what bumped up the figure of merit. So yes, it's dose efficient, but is this image quality sufficient for what we're trying to do? So in summary, the image quality analysis demonstrated that for matched dose, the tin filter at 100 kVp is very dose efficient, but at matched quality, either the 70 kVp or the tin filter at 100 kVp, they're comparable. They're both good for the task. Appropriate, I should say. So the third objective was to use the phantom to perform dosimetry measurements. So I wanted to make this dosimetry assessment as clinically relevant as possible. So the protocols that were selected were chosen with the help of a senior medical imaging technologist at a paediatric hospital. And so you can see that it's neither a dose matched nor a quality matched comparison, but instead probably a more accurate representation of a clinical situation. So this is for a low dose, non-contrast, paediatric lung study for general lung pathologies. So the dedicated phantom slices were used, 200 TLDs were used, 4 calibration curves were measured for each protocol, so 4 different protocols, 4 different calibration curves, and the TLDs were distributed throughout the phantom, as you can see, to measure all different dose depositions throughout the structures. So the results of the dosimetry assessment are here. Now, I've just displayed all the different protocols in different colours. And across the board, you can see there's not a lot of variation at depth within the phantom. So what I mean is the dose at the central part of the phantom, the mediastinum, is not much different compared to the skin dose. However, the large variation in dose is seen in particularly the bony structures. So quite clearly the 100 kVp is depositing the most dose, the 80 kVp is close after, and you can see that the tin and the 70 kVp are delivering the lowest doses in all structures throughout the phantom. The doses are not significantly different in any structures apart from one TLD position, which was the anterior ribs. So in this case, the tin filter at 100 kVp was the dose was lower compared to the 70 kVp. So, bringing it all together. Objective 1, so a paediatric chest phantom was constructed, the phantom materials were validated, and the phantom was capable of producing image quality and dosimetry measurements. The second objective demonstrated that for a dose-matched comparison, the tin filter is quite dose efficient. However, at lower doses and matched quality, 70 kVp is as good as the tin filter with 100 kVp. The final objective of the dosimetry measurement suggested that either the 70 kVp and the tin 100 kVp can deposit overall low doses throughout all structures in the phantom, apart from the bones, where the absorption of X-rays is slightly higher in the 70 kVp. Particularly considering non-contrast chest CT studies. For infants, there is no evidence to suggest that there's any advantage using the tin filter at 100 kVp in terms of image quality. There seems to be no improvements in image quality. The only reason why you would use the tin over 70 kVp for infants would be the slight reduction of dose absorption in the bones, in the bony materials. Overall, I think my research has demonstrated that 70 kVp is still comparable compared to the tin 100 kVp. However, the use of the tin filtration comes with a significant increase in tube current, which it applies additional X-ray tube loading, which is likely to reduce the lifetime of the X-ray tube. This is because the tin filter is extremely heavily attenuating. As always, my research could be extended. The phantom could be improved in certain aspects. In particular, the phantom could have little paediatric arms because clinically infants are usually scanned in a baby cradle where they are wrapped up to comfort them but also keep them still and compliant during the X-ray scan. So their arms are actually strapped by their sides, so they'd be in the direct beam when considering a chest CT. This would likely affect the automatic tube current modulation settings that are selected, which could affect the results of this study. As well, the low contrast inserts of the phantom didn't work exactly how I wanted them to. Although they worked, they weren't very close at assessing the resolution, the limitation of the low contrast resolution, which I hypothesise that there is a loss of low contrast resolution using the tin filtration, which I was not able to validate using my phantom. But for now, that's all, and thank you very much for everyone for your support, and thank you for listening.
Great talk. You
Thanks.
conveyed the message well.
Thanks, Mario.
Like that. Speaking of objective 2, you were talking about dosimetry and image quality stuff, and you were talking about tin has lower dose and stuff.
Yes.
And you also put in some MTF.
Sorry, objective 3?
Objective 2.
2? Oh, yes.
And you also, in your phantom for the image quality stuff, you inserted like MTF wires.
Yes.
I was wondering, like, you haven't presented any results from that.
Yes.
And did it affect, because you're also talking about the low contrast resolution, how it could be affected by the low dose?
Yeah.
I was wondering if you could talk about that a bit.
Yeah, so the MTF, the wire that was inserted into the lung, I'll come back over here for the video, was actually successful in producing the MTFs of the images. So I've got results for the spatial resolution information from the MTFs. However, I did have to modify the original design, so I couldn't use the cork material to produce the MTF. The inherent noise in the cork was not appropriate for modelling the point spread function of the wire, so I actually had to use a different material, an EVA foam, which was a lot less noisy, but I was actually able to model the line spread function and get the MTF from the wire, and these are the results. So thank you for asking that question, Mario. It's very prepared.
But it's good because it's good resolution at lower dose.
Yeah, so you can see that the resolution for the smooth images is less than the sharp images, which is expected because it's a smoothing filter, so it's blurring some of the detail there.
But better than the 71, which is also good for both sharp and
Yes, so for the smooth recons, they're about comparable, but for the sharp recon, the tin seems to have a better MTF. However, it was a very noisy image, and I'm not sure if it's actually the represented data, or if you can see here that the MTF rises above 1 a little bit in the red one, which is the tin noise, and that could be due to too much noise in the image because the MTF is not traditionally measured in a low dose, high noise environment. Typically you need a higher dose to measure the MTF. So. Thank you, Mario. You can ask.
So clinical chest scans.
Yes.
Is there enough of a qualitative difference, do you think, between the 70 and the 100 filtered to ever recommend 70?
I think that it depends on the diagnosis. So you'd never use the tin filter if you were looking for, if it was an oncology patient and you're looking for soft tissue nodules. However, for general lung pathologies, you want, and you don't know that they've got cancer and you're not looking for that high level of dose and image quality, you can recommend the tin because you can get that dose savings with a slight loss of image quality. So for higher requirements of image quality with the justified increased dose, then you would recommend the 70 kbp. But you would also be changing factors like the pitch and the slice, which I assess them all for like a low dose scan, typically. Mashid, you can ask now.
I have a question about your dosimetry.
Yes.
So you mentioned the TLDs.
Yes.
You have insects for them. So how many TLDs could you fit in each
Oh, in just the one insert? Just one.
Just one.
So they came in capsules, and the capsules were just slightly longer than the thickness of my slice.
From Royal Perth?
Yes,
Yeah.
from Royal Perth Hospital.
So you put one in each point, and then how many times do you do?
Yes, so that's a good question. So the process was I used the Phantom, and there was 13 placements of TLDs, and I would put the Phantom in place and scan a number of times to accumulate enough dose. Replace the Phantom, replace the TLDs. Did that 3 times. So there was 3 trials, and that process happened 4 times for the 4 different beam energies. So.
And then how much uncertainty did you consider for your TLD measurement?
Yep, so the uncertainty was mainly came from the calibration curve, from the calibration TLDs, rather than the positioning or changing the TLDs, and that was about 10%, which was, it's actually indicated, the relative uncertainty was indicated on as the bars on the graph, but this was corrected per scan. So I did 20 runs to reduce that uncertainty. So corrected for just 1 run. That's the relative uncertainty indicated on the bars. Thank you. You are Rik. Hey.
Great presentation, Sinead.
Thank you.
Why did you opt to choose for TLDs in place of other dosimetry verification methods?
Consolidation with my supervisors is the main answer. I think that I wanted to gain experience using the TLDs because that's sort of what we have access to them from Royal Perth, and we also use them a fair bit in diagnostic imaging measurements that I do at work. So it was more of a learning experience.
Did you look at any other your measurement tools to use?
Like film or... I did. Well, I didn't. I did, but Martin and Pejman told me maybe go TLDs.
Shifting the blame.
The film is for radiotherapists.
Yes. Yeah. I was hoping.
So, any questions from Zoom? Happy everyone?
Yeah. Oh, sorry. Just quickly.
Sure. Brendan.
How did you measure your CTDI to match your CTDI for image quality assessment?
So for the image quality assessment, I just used the displayed value of the CTDI from the scanner, but a separate part of my project was validating that CTDI. So I did the traditional method of using a pencil ionization chamber to measure the CTDI, and I compared it to the displayed value on the unit so that I could trust the value that was displayed on the unit, just to use that for the image quality assessment. Does that answer your question?
Yep. Thank you very much.
Thank you. It's
Any
weird
other
talking to a computer.
Yeah, I had a question, just a very general question though. Your objectives that you showed, I think in the second last slide, which stage do you think took up the most time in this project?
I started doing this objective 2 and 3 about a month ago. So the Phantom took a long time. Yeah. I thought it was interesting. I thought when I did my project proposal that I was going to make more than one Phantom, which is just hilarious now that I think about it. But could probably make another one easily now, but it was definitely a journey and it took a long time.
So would you say that making the Phantom was the greatest challenge of the project?
Yes. Yes, I would. Yeah, it was a big learning experience.
That's a try and
Yeah, many. It was a long story short.
That's great. Any other questions? No? Brilliant.
Thank you.